Assalamu alaikum, Haifa. Everyone, welcome on board. Dr. Haifa, are you listening me? Okay.
Hello,
Actually,
Zishan.
Assalamu alaikum. Actually, yesterday we discussed scoliosis, and some of the points actually because it's a long topic. There are so many topics which is related to it. So I was telling one sort of scenario, but I forgot to discuss the other part. So I will just take few minutes for some points which I missed yesterday in scoliosis. One of them was that we discussed that there will be problem in the conduct of neuroaxial anesthesia. Okay, so how to deal with it? Haifa, what can be the answer? Like if you want to give spinal or epidural, okay, by which way you can ease yourself?
For cases of with scoliosis, you mean?
Yes.
I think because it is some sort of deformity, angles, and I will prefer ultrasound guided.
Very good. Very good. So for ultrasound, what will be your answers? You will get the midline, and you will get the number of space in which you are, and you will find the distance between the skin to the space. Okay. So that can help you in dealing with such patients. So this is the point which I forgot to tell. And one more thing about this, because we discussed some points of blood conservative strategies, but actually this is very important. You have to use cell saver, and you can do some normovolemic hemodilution, or because this patient might, if there is, because there is no generalized approach, and you make your plan according to the situation. If there is not much of cardiac failure, you can give more fluid as well. But in some conditions, when you have limited cardiac reserve as well, which can be there in this scenario, so in that case, you need to give slightly restricted fluid. Okay, so in that way, you should be doing this blood conservative strategies. Okay, so we will start rheumatoid arthritis. So just like we started yesterday, I will ask the same question, that if you have a patient with rheumatoid arthritis, what will be the challenges to anesthetist? What will be the problems which will be related to rheumatoid arthritis? Yes. Who wants to speak? Yes, Haifa.
Yes, rheumatoid arthritis is a systemic disease. I mean, it is affecting many organs,
Yes.
spine, like cervical spine. We have yani risk of difficult intubation, and inserting line because of deformity of the hands positioning, and also systemic, respiratory, and cardiac involvement. And most of them, they are under steroid drugs. So this is also another risk of metabolic disease. I mean, metabolic. I read it a long time ago, but this is
No
what I
problem.
remember now.
Yes, you are absolutely right. Use the word multisystemic involvement, because there is multi-systems which are involved. Okay, so it is involving multi-systems. Okay, and some of the problems are related to the disease pathology itself, and some of the problems are because of the medications. Okay, so some of the problems will be related to the disease pathology itself, that will be because of association with other autoimmune disease. Okay, and this will be also related to the airway involvement because of atlantoaxial subluxation. Okay, this is one thing. And because of involvement of what other joint will make your intubation difficult? What will be that joint?
Arsinoid.
No, temporomandible,
No,
TM joint. TM joint and
yes, yes, yes. Fibrosis and stiffness. Yes, yes.
okay, so there will be problem in opening. So one will be that you will have if you manipulate too much, it can cause a problem because of unstable cervical spine, and there can be limited mouth opening because of TM joint ankylosis. So this is two things. The other systems will be like pulmonary hypertension, restrictive lung disease pattern. Okay, and as you told, problem related to IV lines, problem related to positioning. Okay, and involvement in the lungs, may be nodules. I'm just giving you a summary, and then we will discuss in detail these points, but these are the main points. And the things related to the medications will be like this patient will be on which medications. There is, how will you define the medications in two groups? If I ask you to divide medications in two groups.
This chemo, some of them they have suppressing the immunity, and even chemotherapy and steroid.
Yes. Yeah, though, so one are for the symptomatic relief and one are for the disease modification. Okay. So
Yes.
the main medication for symptomatic relief will be NSAIDs. So there will be problems related to NSAIDs, and you are suppressing the immunity. And there are some disease modifying anti-rheumatoid drugs. Okay, like penicillamine, gold, and this methotrexate. So these medications have effect on almost all system: bone marrow, renal system, liver. Okay, and other problems, other systems. So actually you can speak anything any bad thing will be there in a patient with rheumatoid arthritis. Okay, so this is in addition to that, there will be problems related to if rheumatoid arthritis is associated with some other autoimmune disease. Okay, so there are involvement myasthenia gravis, thyroid. So I don't know how to pronounce it, Sjogren's syndrome. Okay, so things like that. So these are the main things which you will be facing when you are we are dealing with a patient with rheumatoid arthritis. Okay, so if you are making any positioning, you have to taking care of, and if the patient is on steroids, you have to give the steroid replacement. And if there is immunosuppressants, you are anticipating all the bad side effects. Okay, so now we will discuss in a little bit more detail. So okay, so what is like how to diagnose rheumatoid arthritis? It should not be your it is a clinical diagnosis, because in some patient there is this presence of RA factor, rheumatoid arthritis factor, but it is not mandatory. Okay, so usually it's diagnosed on the clinical basis. So there is involvement of multiple joints, as they have tried to explain here. Like there are actually, this is too much details, because it may be involving one joint or multiple joints. There will be deformities. So just a second. Diagnosis. What will be the diagnostic criteria other than that? What other investigation you need to do? Somebody is moving this. You see how this is irritating for me, because somebody is moving the finger and this is lines are coming. So please don't do it. Okay. I was just looking at the diagnosis. This is association with the human leukocyte antigen DR4. This is, they may be asked you in MCQ. Okay, female gender, it's more common. Family history, okay, and these are some. Yes, I think I was disconnected. So can you hear me now? Can you people hear me now?
Yes, sir. Yes, sir. Now it's great.
Yeah, better.
Okay, so why was I? Just a second, please. Okay, can you hear me now? Yes, what was the last thing? What thing I was saying the last, please? From where I disconnected?
Uh, we lost when we are sharing the PDF for the anesthesia and the clinical diagnosis.
Yes. So how to diagnose rheumatoid arthritis? Actually, I think it will be clinical. Some RA factor, not in every people. Okay. And these are some of the other factors, female gender, as I told you. Okay. So okay. So if we just have a look on this painful joints, morning stiffness, okay, and what is that? Symmetrical joint involvement, okay. Usually there is symmetrical involvement of joints, and especially usually it can affect all the joints, but usually they started with the hand, okay. So wrist, fingers, and then neck, shoulder, and actually it can affect any joint, okay. And there will be soft tissue swelling, raised temperature, tenderness. These are actually, this may not be asked you in every exam, okay, but you should be knowing about it, because in some of exams, like in back in Pakistan, or even in Royal College exam, they can ask you in a scenario, but in actually in Pakistan, in long case, they are having the real time patient. So rheumatoid arthritis can come in a long case, in which you have to take the history and examination, and then you have to prepare that patient wholly solely. So for that thing, you should be knowing the some of the clinical features, because when you are taking the history, you will be looking taking in consideration these things. Okay. So let's concentrate on this cervical spine issues. There is actually atlantoaxial subluxation. Okay. And usually there are four subtypes. This is most common anterior. Okay. And actually, this is the one thing which is important, which I am just showing here. Anterior subluxation, worsened by neck flexion. Okay. So if the patient is having worsening of the symptoms in flexion, so it may be anterior atlantoaxial subluxation. Okay. And posterior with extension. So this is a point which you should be knowing. This may come in MCQs. Okay. And for that, you need to do the peg view X-ray, and you can also do CT scan to confirm about it. Okay. And it will also having the neck pain, and when you have a patient with the atlantoaxial subluxation, you should be expecting you difficulty in intubation, not only because of this thing, and it can cause some neurological problem. So you have to document the neurological status preoperatively, so that if you happen to have something, you are able to look into it. Okay. So the other thing which Haifa you were saying was this, because of laryngeal involvement, cricoarytenoid joint involvement, which may be resulting in stridor, hoarseness, and dyspnea. Okay. And it may result in obstruction. As I told you, they have to do the CT scan. TM joint involvement is big problem. So this patient will be needing fiber optic actually. Okay. By the way, fiber optic intubation, which is better, nasal or oral? Is there any difference between doing fiber optic via nasal route or oral route? Is there any difference? I think
Sure, there is
Local anesthetic. Local
sorry.
anesthetic xylocaine is given in the nasal.
No, 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 no. Dr. Humera, you are not answering the question which I asked. Is there any difference in
yes, sure.
yes, what is preferable, what is ease? I don't know the answer. I'm just asking that which is better. Nasopharyngeal bronchial intubation is a better choice or oropharyngeal?
Oral.
Yes, Haifa.
I don't know, because nasal maybe will be easy, but there is a risk of bleeding or
Okay,
something like this.
of course, you will not do if you have any chances of bleeding. Okay, but I think if you are making in a view, I think it is easier to do nasopharyngeal. I think this is I'm
Yeah,
just
because
guessing. I'm not 100% sure. Okay, of course, even you have to block all the airway, and of course, if there is like chances of bleeding, or then of course you will not do by nasal route. Dr. Humera, I was not asking about the conduct. Okay, I was just asking that which is, if you just, it just strike my mind, so I asked this question.
Sir, I know you are not asking about the method or technique, but I wanted to tell that this nasal blockade fiber optic intubation is more in practice and safe. Like we are
No,
not
no, not
giving
safe.
the
You are
local
not
in mouth.
using. No, 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 no. Please, it's not like that. How can you say that you are not giving local in the mouth? How will you pass through? At the end of the day,
Absorption in the nasal mucosa is good, better.
no. No, 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 no. You are wrong. Sorry. This is not the answer. This is not the answer. You have to block. If this is only the passage. If you are doing oral, you have to put the bite block. Number one. Okay. Number two, angle. You will face difficulty in angle. If you are going nasal from nasopharynx, it will directly it will be easier for you to approach. But this is not absolute thing. You can go by oral as well. Okay, but in either case you have to block the oral cavity. You cannot do fiber optic intubation without blocking the doing the gargles both in mouth, in the throat, and then you can have either of the spray as you go technique, or you can have the transtracheal block. Okay, so you have to block the oral cavity.
also intubation will be, in this cases with some problem with opening of mouth, will be better
Out.
option. If you are trained
Yes,
well with this.
this is another because if you have problem in opening the mouth, then it will be easier for you to approach through the nasal cavity. Okay,
It
so
will be
this is
better.
yes. So these are the other multisystemic involvement like pericardial effusions, pericarditis, cardiac tamponade, myocardial. Actually, the result will be whatever is here. You will be finding the presentation maybe of heart failure. Okay, so for these things you need to do echo. Okay, and yeah, because there is involvement of peripheral vascular system as well. You see peripheral vasculitis, Raynaud's phenomena, there are peripheral ischemias as well, and it's a prothrombotic state. Okay, so you will be looking in in the echo, you are finding any signs of failure. This is the bottom line. And in respiratory, as I told you, there is restrictive lung pattern, because at the end of the day, you should be knowing about the main clinical inference. Okay, so nodules and effusions can be there. Here, don't forget heart failure, and here don't forget restrictive lung disease pattern. Okay, so this is the most important point in these things. Here you will have ischemic heart disease, or any involvement in the form of pericarditis, pericardial effusion, cardiac tamponade, in failure. Okay, and the other, this anemia will be mainly because of the NSAIDs and anemia of chronic disease. Though two factors will be, and also because of the bone marrow suppression, which the patient is taking immunosuppressants. And chronic renal failure from drug treatment, as I told you, hepatomegaly. These, actually, I told you that anything can happen, because some factors because of the disease pathology, and rest of the things are because of the the medications. Okay, so as they have written this question, they can use these words in MCQs: Felty syndrome, rheumatoid arthritis with splenomegaly and neutropenia. You will label it as Felty syndrome. Okay, there is autonomic dysfunction. Do you think there will be autonomic dysfunction? I didn't notice this thing. Anyways, say you can, and as I was telling you, Sjogren's syndrome. So it is with generalized dryness, including dry mouth, dry eyes. So this is also relation with the rheumatoid arthritis. Okay, other autoimmune diseases can be there. So diagnosis, they have written plain radiographs, joints, MRI, ultrasound, and rheumatoid arthritis. And there may be some other other autoantibodies. I'm not sure. I think there are some other autoimmune antibodies, I don't remember the names actually. I cannot recall, but there are some autoantibodies other than rheumatoid RA factor as well. Okay, and inflammatory markers. What will be the inflammatory marker? ESR or C-reactive protein. Okay, so as I told you, there is one is symptomatic relief by NSAIDs, COX-2. Steroids can also give you symptomatic relief, and the other are DMRDs, disease modifying, like anti-TNF. Okay, and this one, penicillamine, gold. These are all disease modifying anti-rheumatoid drugs. So here they have. So you should be knowing the main groups and their main side effects. Okay, so these are different drugs which I labeled you, told you. This is all pure. You can review here, but usually these patients will have depressed immunity and multisystemic involvement. These are the medications. I'm not putting it because it's most of the things are clear. There is nothing significant. You should be knowing the main groups. You should be knowing that one is disease modified agents and one is symptomatic relief. Okay, so there will be problems related to steroids and NSAIDs, and there will be problems related to the immunosuppression. Okay, so they have written the same. This is an article from CACCP. So same things are written here. Nothing different. Okay, so now if you come to the pre-operative assessment, so which investigation would you like to do? Some of them we have already discussed, that we will be doing echo, we will be doing CBC, we will be doing LFTs, RFTs, electrolytes, because everything you have a explanation. Chest X-ray, pulmonary function test, ECG, you can give explanation for anything. And liver function, as they have written here, you see CRP, ABGs to see the baseline acid-base status. Okay, and imaging of the cervical spine. You can give explanation for everything. You should be knowing it. As you see here, X-ray for cervical spine, MRI, ENT for nasopharyngoscopy to see the cricoarytenoid involvement. Okay, because it will create problem in the endotracheal intubation. Even if you are able to visualize it, you will have problem in the conduct. Okay, and what else would you like to do? Any other thing which is not highlighted here? You see, like they have written this point, that even with the joint involvement, even PCA will be difficult because patient will not be able to press even. Okay, and there will be this patient might need post-operative HDU. Okay, because of just a second, decompensation which may occur, and problems related to IV lines, problems related to conduct of regional anesthesia, as we discussed before. Okay, you have to see the anemia. Patient may have cachexia. Okay, like poor. These are the common things. I'm just having a look on these articles to see anything which we have not discussed. So thorough airway examination is important. Okay, and you may need to do cervical surgery if you are having any elective case. To cervical fixation may be needed. Okay. What else? So as we discussed that how will you manage the airway? You might be needing fiber optic intubation. Okay. What about use of LMA? Can you use LMA? Yes, anyone? Dr. Humana, can we pass LMA in these patients?
Sir, hyoid bone injury can occur some people's, but LMA is useful in other cases.
Hyoid bone injury will only be there if you are able to pass through the mouth. So if there is limited mouth opening, will you be able to do the, will you be able to pass LMA?
No, sir. Then
Thank
fiber
you very
optic
much.
is the only
So
choice.
how will you reach hyoid bone? You will only injure when you will be able to pass it through the mouth. So okay. So you have to be ready for tracheostomy in such patients, because this patient might need to do tracheostomy for the management. So whenever you are thinking about it, you should be even the last resort will be tracheostomy. Okay. So we have discussed these things. Yes. Would you like to, what monitoring would you like to do? We discussed about airway management. Any specific things related to induction agent or muscle relaxant? All other people who are not speaking out, it makes me a little boring because I think I am only talking to myself. So if all of you will participate, it will be more, it will be better. Okay. So what will be any problems or anything you would like to consider relating induction agent, muscle relaxant, okay, analgesia, monitoring, fluids,
Yes, sir.
any
No
word?
NSAIDs should be employed.
No
There
NSAID
should
should be,
be minimal use of
okay.
NSAIDs
What else?
and muscle relaxants.
What
This
muscle?
this this also got monitoring for the depths of anesthesia.
Why?
Sorry,
Why you want to use this?
I mean depths of anesthesia. You mean you tell inhalation anesthesia?
No. Mike, I repeat my question. Anything? Yeah, you said that I would like to use this. Okay. So, is there any specific thing which is related to rheumatoid arthritis?
No.
No.
It's
Okay.
not.
So when we are thinking, try to be critical, because this monitoring you can do in any patient. Okay. To monitor
Yes,
the depth of
yeah.
anesthesia. For inhalational agents, what thing you are monitoring actually? It is not BIS. For inhalational anesthesia, how you monitor your depth of anesthesia usually?
And the tidal
And tidal agent concentration.
agent.
Okay. And
Yes.
in modern anesthesia machines, if you have put the data, they will tell you according to the age requirement of MAC. So in the screen, you are seeing 1 MAC or 1.5 MAC or 0.5 MAC. Okay. I repeat, because some of the people will not understand this thing which who have not used the agent analyzer. Okay, so when there is a agent analyzer in the anesthesia machine, okay, so actually in end-tidal, via end-tidal, they are calculating the agent concentration, and if you put the age, they will be telling you that in the mixture which you are giving, how much is the MAC which is being achieved, because you know the MAC achievement is dependent on which factors, Haifa? What
The
factors
Oil
MAC,
will
and
affect?
gas.
Just Dr. Haifa, tell me, please.
the MAC dependent on what? The
Yes.
I think the concentration of the inspiratory gases
Very number
and
one.
the
Number two.
I think the uptake at the level of the
No,
lung.
no, 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 no,
Huh.
no, no, no. That how can you see? You will go into the lungs, Dr. Haifa.
No, no, no.
How will you?
Yes,
How will
yes.
you? How can you see? How can you change the uptake? You will make one thing you told, dial concentration. Okay, this is one thing.
Flow.
Flow, very good. Flow and ventilation. Three things usually. By these three things, if you increase the ventilation, MAC will be achieved early. If you increase the dial concentration, you will achieve it early. If you increase the flow up to which liter, what is the maximum? If you increase it, it will increase, but at some range, it will not affect it. Rather, it will have a variable effect. What is that flow range? Up to?
I think 15.
Very
15.
good. 15 liters.
15.
Dr. Haifa, you are rocking, mashallah. Okay.
Allah,
So
just sharing.
if you
I'm not
increase the
in the
flow
mood.
more than 15 liters, then the gas uptake will bypass it. You will not be able to achieve extra. Okay. So usually this concept is being used in low flow anesthesia. Okay. Because you should never be using 15 liters, by the way. You should be using low flow anesthesia. But for low flow anesthesia, you have to monitor the MAC, you have to monitor the end-tidal CO2, you have to monitor end-tidal oxygen, and you have to monitor the agent concentration, because otherwise if you are giving low flow anesthesia without agent analyzer, it's not safe. Okay, so this is just it came into my mind. And you can monitor BIS if you are giving general and if you are using TIVA. Okay, so usually BIS is used for TIVA, and agent analyzer or in calculation of MAC is for inhalational agent. Okay, so any induction and any words would you like to say for a patient with rheumatoid arthritis, which induction agent will be better? Dr. Humaira, now you answer. What in induction agent is safe or safer?
So, propofol.
Dr. Humaira, I am very angry with you because you answer wrong. Propofol you can use in any patient. So which agent will be safer? If you want to keep in consideration some of the problems which are there in rheumatoid arthritis. The patient may have heart failure. Okay, so what maybe etomidate. Okay, so etomidate may be needed if you have a problem, but this is another question that usually maybe you will not be needing IV induction in some majority of the patients theoretically. Practically we do it, but theoretically it is better to have a weak fiber optic. If you have any problem in the airway, you will never do IV induction actually. So this is just theoretical thing. And what about muscle relaxant? Anyone wants to answer, please raise the hand. If and nobody wants to answer, then okay, Haifa and Dr. Humaira are all other people are sleeping. Am I right? Nobody else. So what about muscle relaxant, Haifa? What muscle relaxant can you will be avoiding?
Muscle relaxant. I think
Yes.
always depends. I think I will prefer to not be excreted by renal or liver more. I will prefer to be like tracorium, yani short acting and
Okay. So Dr. Mahjabeen, you were saying something, please go ahead.
I was saying that should we avoid succinylcholine, that as it can cause some problem in muscular dystrophies and other problems, other conditions. So is it avoided in rheumatoid arthritis also?
Dr. Mahjabeen, actually, the people working in the part of world where I am residing at the moment, actually, I will we retract again. But believe me, succinylcholine, there is no indication left. Okay, so actually, succinylcholine is
Okay.
in last 11 years since I am in Saudi Arabia. I think I have hardly used ever succinylcholine. Okay, because whenever we have medications, if you have Sugamedex, even in any patient, even if you have a patient with renal failure, but you have rocuronium available with Sugamedex, so actually you can give rocuronium even in the patients with renal failure even. Okay, you can use.
Actually, I have just started my residency here in Pakistan,
Okay.
and I am not
No problem,
aware
no
of all
problem.
these things.
No problem. I will tell you. That's what that is the even the better to know. Okay, that
Yeah.
succinylcholine actually has so many complications that if unless until it's not indicated, you try to avoid it. Actually, because there are two school of thought. Some people still use it. Okay, but I am just sharing with you that succinylcholine have a lot of problems. Muscle succinylcholine causes hyperkalemia. Okay, succinylcholine
Yeah.
causes fasciculation, which will lead to severe muscle pain. Number two. Number three, even if you are claiming that you are doing it for rapid sequence induction, actually it increases the intragastric pressure as well. So it theoretically it increases the risk of aspiration.
The risk of aspiration. Okay.
Actually, but you don't quote it. Don't quote it, but you should know it that there are so many bad things about succinylcholine. Okay, but in our
Okay.
setup,
Okay.
of course, there is no other choice than to give succinylcholine and pray that Allah help us. So
But
Yeah.
in Pakistan you have to say Saksa if you are doing RSI.
rapid sequence,
Yeah.
because
Yeah.
yeah, because in patients with anticipated difficult airway, in the exam you will never say succinylcholine. You remember this thing.
Okay.
In the exam, if you are being asked this question, that I will be preferring to have awake fiber optic. That's it. For academic purpose, you should be answering this thing, because even if you are giving succinylcholine and you are not able to ventilate, as this can occur in this patient, you cannot manipulate too much and you are failing to into, like for example, there is no mouth opening. How can you give succinylcholine? Can you give? You will not give.
Um.
You will not give. Okay, practically forget
So
about
what
it,
will
that
we do for that patient?
you have to do awake fiber optic. That's what I'm telling you.
Okay. Okay.
There is
Okay.
no other way. Either in exam, either you will say awake fiber optic, okay,
Yeah.
or inhalational induction with fiber optic. This is another option. If you
Okay.
have not, if you are, there is no risk of aspiration, okay, and then you
Without
can say
relaxing the patient.
without relaxing, keeping the spontaneous ventilation intact. Keeping the
Okay.
spontaneous ventilation intact, you can have inhalational induction, but you will never give muscle relaxant if you have any doubt. Because once you
Okay.
give muscle relaxant, the patient will be out of your hands. And in academic forum, you will always say, practically we don't do it. I again repeat, but in
Yeah.
academic forum, you have to say, or you have to keep in mind that you have to be ready for tracheostomy. Okay. In this
Okay.
scenario, you always have to see, because you will not be able to pass LMA. So what else is left? You have to, you will have no other option than tracheostomy. Okay.
Um. Yeah.
Okay, can I ask a question, please?
Yes. Sorry, by mistake, I mute you, Dr. Mona. Yes, you are welcome. Yes, Dr. Mona, you are mute by mistake. You can unmute yourself.
Okay, now you can hear
Yes.
me?
Yes.
Okay, what about if it's a case of emergency? Like there was a question asking about rheumatoid arthritis and patient was undergoing emergency CS.
Emergency CS. Okay.
Yes. So the only option was to give rapid sequence induction and go for another thing like a glidoscope or CMAC, and to be standby with tracheostomy in
Yes,
case before
this is one
intubation
thing.
I cannot
Other
access.
thing,
Yes.
was it being asked in MCQ or was it being asked in oral part?
Oral part in
Okay,
Saudi Arabia.
okay. So actually, in oral part, if you are talking about oral part, you will be saying that I will be trying to have regional. Okay,
It
of
was
course,
emergency with fetal distress.
fetal distress. Uh,
Yes.
still, because who is priority?
The mother, I know,
Mother.
but
Okay.
the question was that in at the beginning, he
Mhm,
was telling that the mother was refusing regional when rheumatoid arthritis, so we went for regional anesthesia. He told she was refusing regional, so
mhm,
we went for awake fiber optic. Then he make it more complex.
mhm,
There is fetal distress now. What to do?
mhm. Of course,
So
Uh,
I,
any information regarding mouth opening?
no, he didn't tell. It was just a case of rheumatoid arthritis. So I
Mhm,
told there is no other option because it's emergency situation. So we will go rapid sequence induction. I will try with CMAC.
mhm,
If not accessible, so I
mhm.
will announce for ENT to be ready for tracheostomy. This answer was
Yes,
accepted with him.
yes, and
Yes, it
actually,
depends upon the mouth opening. If the mouth opening is very limited, still you cannot do RSI. You have to go for a tracheostomy or awake fiber optic.
Yes.
because in this scenario,
Okay.
actually,
Thank you.
some things are gray area in our anesthesia practice. Okay, I will give you a
Mhm.
similar scenario. You have a patient with thyroid and you are not able to ventilate, you are not able to intubate. How will you do even tracheostomy? Just tell me. Can you do tracheostomy? Yes, Dr. Mona.
I cannot
Okay,
intubate and yeah. Mm.
what will you do? Usually, if it is a big thyroid, okay, usually if it is a
Uh,
big thyroid, the
uh-huh.
the
The tracheostomy
option.
is difficult. So we can go for rigid bronchoscopy in this situation
Very good.
because it's
Rigid
not
bronchoscopy
accessible
is one.
tracheostomy.
Yes, rigid bronchoscopy is one answer. Making the patient turn to the lateral is another answer. And doing reverse salic maneuver by lifting the thyroid, okay, to relieve the obstruction.
Mm-mm.
Yeah, and of course, rigid bronchoscopy will be one option. Okay, so
Mhm.
actually, in this scenario, because since you are in Saudi Arabia and you can understand that you here the quality of medical services is much better. So usually we don't see such thyroids as we see in other parts of world. Okay, so usually in Saudi Arabia you never face. I have never seen a thyroid like I used to do in Pakistan. I never saw that thyroid in Saudi Arabia. Never,
Mhm.
never ever. Okay. So actually, Mayor, maybe you will be able to do something. But when they are asking you in the exam, you did the correct answer. Another option as the Usman mentioned, that you can if you have no
Mm.
mouth opening, then you cannot do this one. Another option will be if you are able to keep the spontaneous ventilation, you can try
Mm.
nasopharyngeal sleep rather than awake fiber optic. You can have sleep fiber optic, okay, via nasopharyngeal route. This is another option
Yes, under GA. You mean fiber optic under GA?
yes, okay. But
Yes.
if you have a patient with full stomach, then again it's a question mark, okay, because in that scenario you
Mhm.
are not able to, then you will be doing the other actually not only for exam but for safety purpose as well. What you can do is you can make the ramp position, okay. If you make the ramp position, actually ventilation will be easier, and actually the risk of aspiration is reduced because there is against if the intragastric pressure has to go higher up to cause the aspiration, because it has to go against gravity, okay. So if you are
Yes.
making the ramp
Thank
position, it
you.
is also increasing your reserve, is making your ventilation easier. Even FRC will be improving if the patient is on spontaneous ventilation. FRC will be increasing, and if you are
But I think it's
yes.
regarding that position, it's more beneficial in obstetric patients and obese patients because like you said, to improve the FRC and improve the ventilation for the patient, which will raise the oxygenation, even when we are doing the head up position.
Yes, yes. Actually, some things are a practical conduct of anesthesia is sometimes different. I will just share my experience that I never use this RAM position, and because I have never done these bariatric surgery. Okay, then I saw when I encountered for the first time bariatric surgery, then I realized that actually, as an anesthetist, if you are always making this RAM position, actually you are making your life easy always. Okay, so if there is no problem in making the RAM position, you can just do the head side up, and this will make the oral angle, the pharyngeal angle, and laryngeal angle easy. Number one, increasing FRC, and you can manage your airway easily. So you can do the RAM position actually in practically every patient. There is no contraindication to do RAM position. Okay, so this is just another point. So we just discuss about airway now, and we will come back to rheumatoid arthritis. And what about we discussed about airway management, we discussed about induction agent, we discussed about muscle relaxant, that you will try to avoid. If you don't have Sugammadex, you will not be giving rocuronium. The best option will be in that case is cisatracurium. Okay, and pancuronium and other vecuronium you will not be using. You will try to use either cisatracurium or atracurium because they have limited metabolism in the liver. Okay, so you can use it relatively safer. If you have Sugammadex, rocuronium will be a better choice because the compound which is formed by Sugammadex and rocuronium is excreted unchanged, and it is not toxic. So this may be the answer. Okay, so what about monitoring? Because we have taken a lot of time, but with regards to monitoring, you will be doing you will use the word, or you should be thinking, in addition to standard 1, standard 2 monitoring, you will be doing intra-arterial blood pressure monitoring. You may need to have cardiac output monitor. Okay, Mahjabeen, if you want to answer, I will be very happy. What do you mean by standard 1 and standard 2 monitoring? Because maybe
I really don't know.
Okay.
What does it
Okay,
mean?
Usman, are you here? Would you like to explain to Mahjabeen what is standard 1 and what is standard 2 monitoring?
Can I answer? Hello?
Yes. Dr. Mona, you want to explain? You can explain.
Yes. Standard 1 monitoring means to be expert anesthesia in the room. For standard 2 is the basic monitoring,
Like
which is ECG and saturation, non-invasive blood pressure and temperature, and entitled
temperature
CO2.
and tidal CO2. Okay, so if you make an order, the standard 1 monitoring is the presence of anesthetist all the time throughout the surgery. This is standard 1 monitoring. Okay, and what do you mean by standard? These are standards set by American Society of Anesthesia, and we have to follow it. Okay, so this is standard 1, and that standard 2 monitoring is according to airway, breathing, circulation. So if you make like that, it will be easier for you to remember. So airway, breathing, circulation. So it in the form of pulse oximeter, end-tidal CO2, ECG, non-invasive blood pressure monitoring, temperature monitoring, and all other monitorings. All other monitoring is additional. Like if you are using intra-arterial invasive blood pressure monitoring, this is extra. If you are doing cardiac output monitoring, it is extra. If you are passing CVP and you are monitoring the CVP pressure, it is extra. If you are monitoring the urine output, it is extra. If you are monitoring the BIS, it is extra. If you are using the agent analyzer,
Sorry to interrupt you. What is
Yes.
BIS?
BIS. It is bispectral index. Okay. It is actually, if in simple words, just tell me one thing, Mahjabeen, what is how to see the brain activity? What is the thing by which we see the brain activity? What is that? Just like
I don't know,
ECG.
sorry.
No, you should,
Yeah,
you know, and you will be able to answer. Okay. What is the ECG of brain?
EEG.
Very good. Okay. So EEG, you cannot You cannot understand, even we as a doctor, we are not able to understand the ECG. How will we understand EEG? So Allah helped us by making, there is a processed EEG. Okay. So there is a mechanism by which they are processing the EEG and they are giving you a number. Okay. They are giving you a number, and the number is telling you the depth of anesthesia. Okay. Like, for example, if the number is more than 80, patient is awake. If it is going down around 60 to 80, patient is sedated. And if it is between 40 to 60, patient is in deep anesthesia. It is adequately anesthetized. And if it is going less than 40, you need to decrease the depth of anesthesia because patient is too much deep. Okay. So this is a dimensionless number. It's a dimensional number. And similar to this is another monitoring, which is entropy. I don't know much about entropy, but it is also has the same mechanism. It is difference between, I think, two companies. One is entropy, one is BIS. If anyone knows any other difference, please, I will be very happy to be updated. Usman or anyone knows about difference between EEG and entropy?
Sir, I think it's the same one, processed EEG, both entropy and this.
So it
there
has
are
the
other
same.
Also PSI, cerebral spectral index, PIS is also there. So everything is there are all other, but the main mechanism is same, that they are processing EEG.
Okay, so I have made the life easy for Mahajabeen to understand that EEG is the ECG of brain. And if you are processing it and making it easy for you, there is a, just like ECG electrodes, there are electrodes which are placed on the forehead and temple area, and it is giving you a number. Okay, so understand, Mahajabeen? Okay.
Yes,
so
I understood.
the basic monitoring is ECG. ECG to say the rate, the rhythm, usually any ST changes and any electrolyte imbalance, usually, because you will not be able to pick everything correctly on the screen. So if you have any doubt, you will go for to a 12-lead ECG. Okay, you are using the blood pressure to see the status, hemodynamic status, and if you have any doubt, you are not able to monitor it via non-invasive, you have to do the invasive blood pressure monitoring. So this is the concept.
So both the non-invasive and invasive monitoring are included in standard 2 monitoring?
No. That's what I'm telling you. The normal standard 2 monitoring is only pulse oximetry, ECG, and tidal CO2, and temperature, and non-invasive blood pressure. This is finished with standard 2 monitoring. So whenever, if someone asks you about monitoring, you will be saying that in addition to standard 1 and standard 2 monitoring, I will be doing this. This should be your answer forever. Okay. And now another question to you, because it's nice to see a first-year resident here. Just tell me one thing: if you have a pulse oximeter and you have end-tidal CO2, which thing you will choose?
Pulse oximeter.
No. Okay.
No.
End-tidal CO2.
Why?
End-tidal CO2. Okay. Pulse oximetry will have a lag. Okay. If, for example, you try to disconnect the circuit and see the time after how much time the patient is getting desaturated. Maybe the circuit is...
It will take some minutes.
It can take few minutes.
Yeah.
Different patient.
Not minutes.
Huh?
Seconds would be the better answer, not minutes.
Okay, fine. But actually, theoretically, if you are giving 100% oxygen, it can take up to 4 to 5 minutes even. It may to desaturate. But of course, you are absolutely right. If you are giving there will be so many factors to affect this change. Okay. And at the end, but if you are using end-tidal CO2, immediately, as soon as the circuit is disconnected,
the curve will disappear. Okay, now I understand.
Okay. So, and another thing is that if there is no cardiac output, cardiac output, end-tidal CO2 will be lost early. That's why you use, if someone has to choose between end-tidal CO2 and pulse oximetry, you will be surprised to know that end-tidal CO2, even if a patient is spontaneously breathing, okay, you can put the end-tidal CO2 sensor and it will give you whether the patient on spontaneous breathing is breathing or not. Okay. If you have, so that's why entitled CO2 is the even if you of course you will never choose a selection. It's not matter of selection, but actually more important is entitled. Okay.
Because
So,
Untitled gives you a lot of information than
and
pulse
more
oximetry.
information than
It will
pulse
give
oximeter.
you, yes,
And pulse
it can give you
oximetry has a
pulmonary
lot of
embolism, cardiac arrest,
very good.
ventilation, and other diagnoses
rebreathing
also.
and other things. Yeah, some of it I have read in my part 1 exam.
Yes. And one thing I will use this forum to send a message to a budding anesthetist. Please come out of a very terrible book which every of your senior around you is asking you to read. That is the worst thing which you can read in 2022. Okay. I even don't want to take its name. You know about which book I'm telling. Okay. So that is the bloody Manhus Morgan Sharif. So if you want to learn something, please keep yourself as much away from that stupid book as much as possible for you.
So
Okay.
what should we read now? As
Uh,
I have started few weeks ago, and everyone is
articles.
asking me to read Bournemouth.
Everything. I will request you. uh, Articles are the best source. The review articles which I have arranged here, you can see this. I will show it. You can contact me anytime. Okay. And I can tell you, but let me finish this topic,
Okay.
and then I will show you. Before we finish, I will show you how to use this link. Okay. So I think we have covered most of our things. If you have patient on steroid therapy, you have to replace the steroids. Okay. You have to replace the steroids. And rest of the thing, anything, Usman, please, post-operatively, patient should be monitored in this one HDU, multimodal analgesia, as we talked. PCA is a good choice,
Yes,
but
DMARDs should be start as early as possible.
as early as possible. Okay.
DVT
So,
prophylaxis, early mobilization, another H2 antagonist PPIs should be given if, especially if the patient is on NSAIDs.
of course, of course. So these are the things which you will be considering in a patient with rheumatoid arthritis. Airway, 4 times airway. Okay. And multisystemic involvement and complications related to the medications. I think if anything I missed, please tell me before we finish. Usman, you can recall, and I will just show these people the link. Okay. So actually, this is I have just arranged. These are, by the way, this I'm speaking out for Mahjabin. Okay. Or any junior resident or anyone who is new to our discussions. You see this link I have shared multiple times. This is, by the way, these are review articles, not research articles. Research article is the one which you do for one specific study, and that is of course never reliable. The synopsis or dissertation which you people do is actually the research, and at the end of the day which you prepare, whatever inference you are getting is research article. Okay. But review articles is on the basis of 100 or 200 or whatever according to the topic. All the research articles, on the basis of them, they write articles which are actually the most reliable updated source. Okay. So I have arranged them in these links. There are actually 2 links. One of them I was show you that, then I make this one like that as well. It is one you will find topic wise and one you will find year wise. Okay. So year wise, you can see these are 3 sources. This is one is BJA Education, British Journal of Anesthesia Education. These are anesthesia tutorial of the week. And this is another source, anesthesia and ICU. So I have arranged actually, this is a very tiresome job. I have got this is paid articles. I have got the subscription and I just update them. Okay. So you can find all the topics over here. And the information which you will be getting, I can guarantee you that there will be nothing more updated than these one. Okay. So Yeah, this is to see via the year wise, okay, and the other is via the topic wise. So if you want to read like from where you will find this thing, you will find here trauma, orthopedic, and rheumatology. So you will go here and then rheumatological disease, you will find rheumatoid arthritis. Okay, and then you can read anything about it. Another way will be that if you want, if you are a lazy person, you will just write here, okay, rheumatoid arthritis, and you will find this folder directly. Okay, so either you will find in the form of abbreviations, like if, for example, you want to see ARDS, so you will write here ARDS, and I have made a folder for ARDS, you will find here. So you can find any topic here, and if you become familiar, after some time it will be easier for you to target. So this is the best way you can, and for example, if you find more than one article on same topic, like for example, if I go to maternal hemorrhage, okay, you will find 4, 5, 6. So use them like a bank. I will take it in a funny and lighter mode. As much as number of clothes a woman has in his cupboard, she will never be hesitant to buy another cloth, and she will use it. She will open the drawer and cupboard, and she will say, "Oh my God, I have no dress." Okay, so she will never be saying, "Oh, where? How will I read? How will I wear all of them?" Okay, so you should also say the same word here. How will I read everything? You don't need to cram each and every line. The way which I show you how to study, that's the way. Where as I was just focused, and this is a baseline for any disease. You will be approaching like that. Like rheumatoid arthritis, we started. What is rheumatoid arthritis? How to diagnose? What are clinical implications? What are anesthetic problems? And you fit it in every step of anesthesia. How to do the induction, how to do the airway management, how to do the pre-operative assessment, how to optimize the patient, how to look into the systemic involvement. That's how you should be doing for any patient, for any disease. Okay, I hope you are understanding. Am I right?
Yes.
So if you are thinking that the way which was adopted in 1920 cannot be adopted in 2020, am I right? Yeah, like 100 years ago, people used to cook food not with gas. They used to cook food with the burning the wood. Okay, and now nobody will be doing it. And now, if we want to warm the food, nobody will be opening the stove. We are using microwave oven. So if someone is asking you to use stove for warming the food, you will be looking at surprise. I have a microwave oven. Why should I use it? Or why shouldn't I use it? Similarly, you will never use the hand chopper. You will be using the electric chopper to chop the spices or anything. Okay. So similarly, if an old senior supervisor, with all the due respect, if he or she is telling you are the immediate seniors who are only Morgan is mandatory. Paper comes from Morgan, even the examiner read the Morgan. So I can only pray for them. I cannot do anything. Okay, it's up to you to choose what is your fate. You are intelligent enough to decide. Okay, so this is the way, and I am just a message away to everyone. Okay, this is my passion, and I am doing it out of my passion. Now I don't have any personal interest. I am not in Pakistan. I am not in any race of favoritism or personal projection. I'm doing it for you people. Okay, and yes, my only interest that I am updated. This is the only advantage which I am getting. Okay, so you all are welcome to ask any question anytime. So any point to be discussed before we finish?
جزاك الله دكتور خيرا دكتور هشام. This lecture is saved. We can يعني again listen to it or no?
This is one thing. One other thing is that I have around 5,000 people with me on WhatsApp group and only 1,390. I don't know what I will get if I have more subscribers, but I am requesting you to subscribe so that you are able to find all things easy. Okay, if you go to this channel, you will find here in contents, you will find everything which is even yesterday we did scoliosis. You will find it. I will upload it after some time. before maybe
What's
2
the
to
name
2 to
of your page? Channel?
I send it. You got the request from WhatsApp, or you got the request from Facebook?
I got this from WhatsApp.
Okay, so if you follow the WhatsApp group, I send every other day or every third day. I send it. But this is the name is anesthesia knowledge. Okay, and you will go to the contents. You will find everything. Or another way is to go to a playlist. Okay, I have made this playlist, and because before maybe 2 to 3 months before, I used to do the discussion in Urdu. Okay, so after later on, I just converted it to in English. So all the English discussions are here, and for all you people, you can approach everything by all the playlist. Okay, so you can find any topic you want. Ortho, like you will find this in ortho here as well: pediatric anesthesia, laparoscopic surgery, ICU, elderly, pre-operative. Like you will find the playlist for everything. Okay.
Okay.
I would suggest the juniors to have a look here as well. Career counseling, which you nobody does for you. Okay. So all of you, thanks a lot for your presence, and anything miss, you can ask. Okay. So we will do some other topic tomorrow, inshallah. Assalamu alaikum.
Walaikum
Thank
assalam.
you.